All right, we're a minute after 12 o'clock, so we'll go ahead and get started with today's webinar. Welcome. Thank you so much for joining. We have an interesting topic today, enhancing oncology safety, strategies for developing robust IV pump drug libraries. My name is Sammy Burton. I'm a pharmacist by background and a medical science liaison with Baxter Medical Affairs Infusion Systems, and I'll be your moderator for the webinar today. Before I introduce our speaker and give her background, just a few housekeeping items. Thanks, Emily. So this screen should look like what you're seeing on your desktop now. Just wanted to orient you. You should have that top toolbar and the Q&A icon is highlighted there for you. If you click on that, it will open a side panel and then you can type your questions in there. Feel free to submit questions at any point during the presentation. I will be monitoring those, and then we'll have a Q&A session once Emily's presentation is done. And then also a reminder that we are recording this webinar, so the recording will be posted to our medical education website probably within the next week or two. And if you're not familiar with that website, we have a link to it at the end of the presentation. So I have the pleasure of introducing our speaker, Dr. Emily Messing. Emily is currently a medication safety officer in the Boston area. She received her Bachelor of Arts in Biology from Colgate University in Hamilton, New York, and her Doctor of Pharmacy from Toro College of Pharmacy in New York. Emily completed her PGY1 pharmacy residency at Montefiore Medical Center in Bronx, New York, and her PGY2 in medication use safety at Memorial Sloan Kettering Cancer Center in New York, New York. Following residency, Emily worked as a clinical pharmacy manager in informatics at Montefiore Medical Center. Her areas of interest include medication safety, informatics, and human factors. Her recent publications include the safe use of IV smart pumps and the role of pharmacists in medication reconciliation process. Emily currently serves on ASHP's Section Advisory Group on Medication Safety and is the chair of the Massachusetts Society of Health System Pharmacists Residency Program Committee. So I am delighted to hand it over to Emily to share how she applies all of her med safety expertise to Smart Pump Drug Library build.
Great. Thank you for that introduction, Sammy, and thank you to the Baxter team for hosting me today. Very excited to be here with you all talking about different strategies for improving safety in the oncology setting using these IV smart pumps. So before we get started, here are my financial disclosures for this presentation. In addition to my financial disclosures, wanted just to provide a little bit more context of where my expertise and where kind of the information that I'm going to be presenting today is coming from. So as Sammy mentioned, my current role right now is in the Boston area, and specifically I work at an ambulatory oncology infusion center. So we have affiliations with inpatient hospitals in the area, but the majority of my work really is in the infusion center. With that being said, though, I do have previous experiences managing pumps in the inpatient setting, specifically in a large academic medical center. So as I go through the presentation today, you're going to see I'm going to be kind of bouncing back and forth between things that we've learned that have worked well in the infusion setting as well as in the inpatient setting. So I hope that all of the topics kind of combined will help give you a good picture of different best practices that you could apply to your practice setting, regardless of what that setting looks like. The one other point that I will make is that I do not currently have pump integration in my current hospital, and my previous hospital also was not live with integration. So unfortunately, I'm not able to speak to that as far as kind of my personal experience, but just wanted to give you guys that caveat for the context of the presentation and also when we get to the Q&A section. All right, so for the learning objectives for today, I hope to start by first reviewing the essential components and terminology of oncology IV pump drug libraries. And by the end of this presentation, I hope that you're able to explain the common challenges that are encountered in the development of IV pump drug libraries in the oncology setting. describe best practices and evidence-based techniques in the creation and maintenance of oncology IV pump drug libraries to improve patient safety. And then lastly, we'll evaluate the effectiveness of current drug library protocols and use data-driven insights to recommend improvements. But before we jump into IV smart pumps specifically, I wanted to just kind of set the grounds and kind of the context of why this is so important for us to be thinking about IV pumps and medication administration. So we all know that medication errors can happen at any stage of the medication use process, but literature has shown that they most commonly do occur during the medication administration phase. And that can look like any different type of medication error. So it could be the wrong dose, the wrong time that the med was administered, or the wrong rate, for example, was administered due to a pump programming error or not using a pump at all. When we think about the oncology setting specifically, oftentimes the medications that are used here are considered high risk with relatively narrow therapeutic windows, where just a small dosing or rate deviation can result in significant patient harm, especially if the medication is administered incorrectly, which brings us to the importance of IV smart pumps, which we'll be talking about today. I wanted to first start with just a few definitions and kind of level set with these terminologies that I'm going to be using throughout the presentation today. So starting with IV pumps. So this is a device that is used to deliver medications, fluids, or nutrients to a patient at a controlled rate. And oftentimes people will use the term IV pump and IV smart pump sort of synonymously. However, the difference is that an IV smart pump specifically is a more advanced version of a regular IV pump. And what makes it more advanced is that it has customizable software, oftentimes known as dose error reduction systems, or as I'll refer to it as DERS, which is a software that's designed to help programming errors by comparing the dose or the volume or the rate that's entered by the end user, which oftentimes is the nurse, but could also be an anesthesiologist, for example, and compares what was entered to the limits that are set by the facility to make sure that the medication is being administered at a safe dose, at a safe rate, within the appropriate concentration range. And so that is the software that we're going to use to help kind of drive safe administration practices, especially in the oncology setting. And we'll spend some time talking about how we're going to do that. So before we get into any more, I wanted to just set kind of the stage for all of you who maybe don't have as much experience with IV smart pumps. So whenever I am talking about IV smart pumps and the use of the software, the DERS, or the limits, I like to compare it to driving on a cliffside highway. So imagine that you are on family vacation, you come across a road like you see either on the left or the right side of the screen. You see it's very, very high up, very windy. Which side of the screen are you going to choose? Which road would you prefer? I think probably my first answer would say I prefer neither of those. I don't want to be driving on a road like that at all. But I think knowing if I didn't have a choice, I would definitely choose the image on the left side of the screen as being the one that I would want to drive on. And the reason for that is that it has the barrier or the guardrail on the side of the road. This is very similar to the use of IV smart pumps. So we know that we're administering high-risk medications in the oncology setting. We know that it definitely carries risk, but we know that there's a benefit to administering these medications to patients. And so we want to take this risky practice and do it as safely as possible, which if you compare it to these roads would be if you're trying to get to your destination, you know you want to get there, but you want to do it as safely as possible by driving on a road that has this barrier on the outside. And so if I'm trying to define DERS for someone who's maybe not as familiar with smart pumps, or this is the first time they're being introduced to the idea of DERS or limits, I then compare it to this. So on the left side, this barrier is similar to infusing a medication with the limits that are available in the pump, compared to the right side of the screen as if you were just administering a medication using a pump with no sort of limit or barrier to keep you within an appropriate range for how the medication should be administered. So in addition to there being limits, the limits can be presented to the end user in various different ways. The first way that an end user or a nurse may come across a limit is one that has been set as a soft limit. So a soft limit allows the user to override the warning and continue to infuse the medication as programmed. But oftentimes we'll program a soft limit or set a soft limit when we want to warn the user that they are running the medication outside of what would be considered a normal limit. So in said other ways, we're saying you can safely administer this medication this way. We're just saying oftentimes you shouldn't need to. And so this can be an opportunity or a point for the end user to kind of pause and say, let me double check the order against the way that the pump has been programmed. Let me maybe bring in someone else to double check it and confirm that this is how I want to do that. That's compared to setting the limit as a hard limit, which in this case, it does not allow the user to override the warning. At that time, they cannot infuse the medication using that drug entry, and instead they would have to flip to using something called basic infusion, which is available on all pumps in order to continue the infusion. So if they flipped to basic infusion, essentially what it is them driving on this highway, or I wouldn't even call it a highway, sorry, the street on the right side of the screen that doesn't have any sort of guardrail or barrier there to prevent them from going over. It's going to let them infuse the medication as programmed, whether it was intentional or unintentional. So if we're keeping kind of in theme with this road analogy that we're using here, I like to think of a soft limit as the barrier that might be available on the two yellow lines, where if you go over it, your car is going to shake. It's going to give you a bit of a warning to say, are you sure you want to cross over into the other lane? But we recognize that there are times that you might need to do that. So for example, maybe the road is closed ahead of you and you need to go into the other lane. We're just giving you a warning to say, you shouldn't have to do this, but I'm going to allow you to if this really is a decision you want to make, compared to a true barrier in the middle of a highway, for example, that you can't just swerve over into the other side, right? It's going to be much more of a physical barrier and preventing you from doing that. And in those cases, we're saying there really shouldn't be ever any clinical scenario where you need to override this. And so we're not going to allow you to do that. So in addition to alerts, which are warnings to the end users, something that we leverage in the oncology setting is something called clinical advisory. So a clinical advisory is a little bit different than a soft or a hard limit in the sense that this is a customizable warning that will appear once a medication is selected, but prior to programming the pump. And this advisory or this warning message will appear regardless of how the drug is programmed. And so this is a warning that must be acknowledged before the drug can be programmed. And I'll go into a bit more details of how we leverage this in the oncology setting to help describe to end users, maybe there's a special infusion practice that needs to be considered with this medication, or other safety features that we want the nurse to be aware of prior to programming it. Next, we have the dose mode. So when we are building out a library, we oftentimes are considering the dose mode that we are going to have available to the nurses in the pump when they are programming a drug. So the first dose mode entry that we are able to choose from is something called a variable dose. And in this case, the dose and the volume are not fixed and must be typed in by the end user, as you can see in the image of the pump on the right. The unit of measure can be either a flat dose, a weight-based dose, or a BSA dosed. And the way that we consider how we want to do what dose unit we want to use for a variable is we look at the way that the medication is ordered in our electronic health record. So there's been a bit of conversations, I would say, among our group about whether we want the volume or the amount to be the final drug amount that the patient's going to be receiving. So for example, if it was a weight-based dose, we would then on the pump allow the nurse to program in milligrams, the final milligrams that the patients are going to be receiving. However, in our oncology setting, we have decided that we want the amount that the nurse is going to program to be the ordering unit. And then that way it serves as a double check for the nurse to confirm that the weight-based dose or the BSA-based dose, for example, that the medication is being ordered in, and then they'll be prompted to enter the patient-specific factors such as the weight or BSA, and then they can compare that to the final drug amount that the pump has calculated, as well as the final drug amount that is available to the nurse to check on the medication administration record in the electronic health record. And so this is a way that we have kind of built in an additional almost double check for our nurses when they're using a variable dose mode to make sure that there weren't any programming errors and that everything matches within the pump and the electronic health record. So there are also some additional pros to using this dose mode. So it allows for flexibility of dose. So oftentimes in the oncology setting, we have patient-specific doses that our patients are receiving. And so we want to make sure that the dose is customizable to the patient and that the nurse is able to program that into the pump. However, there is a risk of programming errors because the more entries that we are prompting our nurses to have to enter into the pump, given that we do not currently have interoperability, we know that each time it is a risk of a programming error, but we'll talk a little bit about some other strategies that we've tried to leverage to either prevent those programming errors from happening or from being able to catch them before the pump is actually started and the medication administration begins. So in addition to variable dose modes, we have something called a fixed dose mode. And so as you can see in the screenshot on the left, in a fixed dose mode, we have standardized non-weight-based doses where we're able to default in the dose and the volume. And so within our setting, we try to do this whenever possible if it is not a patient-specific dose. So the example I have on the screen here is nivolumab, which a common dose that is administered is 240 milligrams. And then we have also pre-programmed in the volume to reflect the volume based off of how we prepare it here within our institution. So a pro of this is that it decreases the chance of a programming error because the values are already pre-populated and we don't have to worry about the nurse's finger slipping or hitting an extra decimal point or zero, for example, which helps also standardize the way that these medications are being administered to our patients. But the biggest con that we have with this is that it does not allow for programming of different doses other than what has been pre-programmed using that drug entry. So for example, in the oncology setting, oftentimes we are trying to ensure that the patients receive the full dose of the medication. So from time to time, we have a patient who is maybe up in the room, their line gets caught, the dose is not fully done being administered to the patient. And so we recognize that we need to make up that dose. If there was a bit of a spill, we want to give the remaining amount of drug to the patient. And so if that was the case and we made a partial dose in a bag, the nurse would not be able to run that medication using that drug entry in the pump. Instead, they would have to flip to basic infusion, which is like driving on that cliffside highway, right, without any sort of barrier there to keep you on the road. So it is something that we will kind of weigh the risk benefit of, but oftentimes we do try to use this fixed dosing scheme whenever we're able to for these standardized doses to prevent the risk of programming errors with these high risk medications. So next, I wanted to cover the topic of modifiers, and you'll see later in the presentation, I'll kind of tie this back to real life cases of how we've used this in the oncology setting. But this first portion wanted to really more introduce kind of these topics and these features that are available in the pumps, and then we'll talk more about how we're leveraging them. But starting with modifiers, so there is an option to add modifiers to drug entries in many of the pumps. And so what that allows for us to do is it allows for one medication that might be administered different ways to have narrower limits so that way, again, we're kind of decreasing the chance of a programming error actually reaching a patient. So in the example that I have on the screen here to the right, you can see a list of modifiers that we've built out in our test library here, where once the end user will choose cyclophosphamide, they are then prompted to choose from a list of 5 different modifiers that we've built out here. The first 3 are all BSA-based doses, and as you can see, we have different dose ranges there. The idea behind this is that we're able to have narrower limits when we have these broken out versus just one entry, whereas you can imagine the dose being from 200 up to 3,000 milligrams per meter squared would allow for any sort of 10-fold dosing errors. For example, if they meant to choose a dose of 200 milligram per meter squared, if they hit that 0 an extra time and typed in 2,000 milligrams per meter squared, if this was just one drug entry, there wouldn't be any sort of warning necessarily to the end user to say, hey, are you sure you want to give this dose? You know, you've typed in an extra 0. And so this is a way that we've found that we can keep our limits a little tighter, and we'll do assessments of what doses could be used in each of these different dosing modifiers to try to keep them as narrow as possible. Below the milligram per meter squared, we have an option for milligram per kilogram, and then also an option for flat dose. So oftentimes in the oncology setting, especially with medications that have been around for a long time, they are often used in a number of different disease states, and they oftentimes will be dosed differently depending on the type of regimen, the type of cancer that they're being used to treat, really based off of how they were studied in the clinical trials. And so we find that the modifiers are a great way for us to be able to still keep all those safeguards that we want to have in place by having milligram per meter squared or weight-based dosing, if that's the way that the medication is being ordered in the regimen, but also by able to keep those limits a little bit tighter, all for the same medication. Great. So now we're going to move on to some of the challenges. I know I've already hinted at a few in the introduction section, but really want to, for the rest of the presentation today, talk about these specific challenges that we oftentimes see in the oncology setting, whether it's the outpatient infusion center or inpatient oncology units. The first challenge that I wanted to highlight here is the fast approvals and frequent guideline updates. So for anyone that works in the oncology setting, I'm sure you're very familiar with this, with how often new medications are being added or approved to the market, or how often new indications are being added to meds that are already existing on the market, or even just changes to the way that medications are administered. And so this is one of the biggest challenges, I would say, that we have in the oncology setting, at least where I have practiced, is how do we keep up with all of these changes and make sure that our smart pumps reflect the most up-to-date practice, but also by not compromising any of our safety checks that we want to have in place by pushing these changes out rapidly. So one of the best ways that we have found to do this is to have an infrastructure in place with an interdisciplinary pump committee that is able to meet at a regular cadence and review all of these different changes or new drug build requests. Having this sort of infrastructure in place already has allowed us to update our pumps monthly for the majority of the time. Every once in a while, we'll have a new med and it's kind of an emergency push, but I would say for the most part, we are pushing library updates on monthly to keep up with all of the new drugs, new practice changes that are happening. So for us, our interdisciplinary pump committee is made up of mostly pharmacists and nurses. So it's led by the medication safety officers with collaboration with informatics pharmacists, clinical nurse specialists, informatics nurses, nurse managers, as well as nurse directors. And the way that we have set up our meeting cadence is that we meet monthly the week after our oncology P&T committee meets. That way we know what medications have been approved to be added to formulary. Also, any significant practice or guideline updates also go through our P&T committee. And so we find that this cadence, kind of marrying it or coupling it with the P&T, is a great way for us to kind of keep up with these changes. So our committee here will review any new drug approvals. We'll also review any pump-related safety reports that have been submitted over the last month. Those safety reports can be about medications not being able to be programmed in the pump, they can't find them in the pump, or if they feel like there is a better way to have the pump set up, we will ask our frontline staff to submit those as safety reports to us so that we can review those on a regular cadence with the committee and ultimately make a decision if a change is needed in the pump. This is a committee that also reviews our infusion pump related data. So we'll review our compliance data, if there's any significant alert data that we want to review. Already having kind of this interdisciplinary committee in place allows us to review that data and again, recommend any practice changes to the pump libraries that we want to. And lastly, the other activity that our committee does is they also participate in the pump change validations. So this is something that we have found to be really beneficial, is having the same interdisciplinary group that was involved in the discussion of the pump changes, also performing validations independently to confirm that all the changes that we had discussed aligns with the best practice recommendations or recommendations coming out of our P&T committee. And that is reflected in the pump. So we have the same group that will validate these pump library updates before they go out on a monthly basis. And having this kind of built into everyone's job roles and responsibilities already, again, has allowed us to consistently keep up with a monthly update to keep up with all the changes that are happening in the oncology setting. So in addition to all of the activities I just mentioned of the committee, we also will have our medication safety officers coordinate any pump updates with other system changes that are happening. And so oftentimes either new formulary additions or practice changes or changes that need to come from feedback from the frontline staff require oftentimes changes that happen in our other systems beyond the smart pumps. So just some common examples here, the electronic health record, our online guidelines and policies, as well as pharmacy inventory. So oftentimes we will work with others that are kind of spearheading the changes in the other systems to make sure that we all have a go live date so that when a new change goes live in the electronic health record, that change has been reflected in the smart pump so that that way nurses or end users will know if I see an order in our electronic health record, I can expect to find that in the smart pump. And that has allowed us to definitely have a strong culture of using the library or using the limits because our users are expecting anything that's been approved for practice here to be reflected and available for them in the IV smart pumps. So even with all of this work, I would like to say that we don't miss anything with the pumps, but we all know that that is just not true and not reality. So even kind of with the strong infrastructure in place, we also have recognized there's still need for our frontline staff to be able to communicate with this IV Smart Pump Committee to let them know if there's a concern with the smart pump, meaning either the medication's not available or maybe the dose or the rate is not able to be programmed into the pump. And so what I'm showing on the screen here is an example of a change that we implemented for me at a previous institution that we used within our medication administration record. And so what you're looking at here is a sample entry of a carboplatin order, again, available to the nurse on the MAR. So this is a screen that they would likely have open while they're doing their clinical check, while they're scanning the medication and going to program it into the pump. And so what we were able to do is work with our informatics team to develop an option within the MAR so that when the nurse clicks on this little RX button on the side of the MAR, a pop-up will appear and the subject will be the medication order details. So you can see here the carboplatin 600 milligrams, for example, and then the nurse can select the reason for them sending the message. So this is where we worked with our informatics team to add the option of medication being run using basic infusion. And then they can go ahead, send that message over. They do have the option to free text an additional message if they want to, but that's not a requirement because everything that the pump committee needs to review this order is already linked to this message through this order. So we can see the medication, the dose, the concentration, the administration time. And so we found that this was a really great way for our frontline nurses to easily and rapidly communicate with the pump committee of any changes that are needed to the pump. So say maybe something new was added to formulary and it slipped through the cracks and we missed it, or there was a practice change in the oncology setting that the pump committee, again, just it kind of slipped through the cracks. This is an easy way for nurses to quickly communicate and send all of the information over to the pump committee so that it can be reviewed and modified if we need to. I think recognizing for us, we really loved having this communication tool available to the nurses in the electronic health record because, again, all of the information from the order was there. They're already in the electronic health record administering the medication, so they didn't have to log out of their system, log into something else or open their email. But recognizing that that is not necessarily an option for all institutions based off of maybe your electronic health record that you're using or any build principles for your organization. I do want to still say, though, that there have been studies that have shown benefit of having other communication tools. So wanted to show that one because I think it's really innovative and, again, just an easy way for nurses to report. But there is data available to support having email communication available. So we do have a listserv that's available for our frontline nurses to send a message to the pump committee. And so it's easy for them. In email, they search IV pump and then it'll pull up the listserv. And then they can send that information over to us. There have been also studies where organizations have had an electronic form available to their staff on the intranet. So again, if they're running into a programming issue, they can go to the intranet and fill out that form. And then lastly, there is a lot of literature of having nursing champions involved in this process. And so anything with the smart pumps, you definitely want to include your nurses and having nursing champions on the floor to reiterate the importance of using the library, but also the importance of communicating when they run into a barrier with the library. They can also help with that closed loop feedback to the frontline staff for them to continue reporting. And then at the end of this presentation, we're going to talk a little bit about the data, but wanted to pull in some data options here as well. So one way that we were able to kind of track the effectiveness of this communication tool, also to confirm that we were really kind of keeping up with the changes that were needed based off of all of the workflows and infrastructure we had in place, is that we were able to measure the number of messages that we received through our electronic health record. But you could definitely do this if emails were being sent to an email communication, or if you were using like an online Google form, Microsoft form, or something like that, you could definitely do that. And what we saw here is that we were getting a lot of messages when we first went live with it, which I think, again, was to be expected. We were kind of starting a new process. We were trying to catch up and make sure that our pump library did reflect the practices that were happening in our oncology areas and infusion centers. But then, as you can see, as time goes by, the number of messages that we were receiving on a monthly basis did decline. And again, I think that was thought to kind of, we did get caught up, made sure the pump was up to date with current practice as of then. And then we were able to kind of continue with updates by following our normal pathways, but continuing to monitor these messages for any changes that might have slipped through the cracks. Great. So the next challenge I wanted to talk about here is high-risk medication. So I know I alluded to this a little bit at the beginning here, but oftentimes in the oncology setting, the majority of medications that we are administering are defined as high alert medications, which we know have an increased risk of causing significant harm when they're used in error. So oftentimes many organizations will classify IV chemotherapy as high alert. And as such, there are a number of different best practice recommendations that come along with that in order to help mitigate the risk that's associated with administering these medications. So very high level, being able to standardize administration, which the IV Smart Pump Library is a very, very powerful tool for us to be able to standardize the way that these medications are administered. And then also another common best practice recommendation is ensuring that there's a manual independent double check of administration. But I'm going to go into a little bit more detail of kind of what that looks like for us in our oncology centers. So for us, I know I mentioned clinical advisories before at the beginning, but this is an area that we definitely lean on heavily and leverage in order to, again, convey sort of administration precautions with these high-risk medications to our nurses. So as a reminder, this clinical advisory is not necessarily a soft or a hard stop. It's a warning that has to be acknowledged once the drug is selected. And it's more of an interruptive alert in the sense that it must be acted on. So we can see, hopefully, if the nurse is looking at the pump and they want to click through this alert, they're going to have to read the screen first and then be able to acknowledge it. I'm not going to go through all of these examples here, but just here are some high-level examples of advisories that we use that are specific to the oncology setting. So the first one here, I have invert drug bag 2 to 4 times before starting infusion. So this is an example of an advisory that we use with our taxanes or paclitaxel, for example, where it has inactive ingredients that are known to contribute to infusion-related reactions. And so some data has suggested that if you invert the bag and you get that inactive ingredient more evenly distributed, it can help prevent infusion-related reactions. And so rather than relying on our nurses to remember when they're giving this medication, which can be given anywhere throughout the hospital pretty much, we use this advisory to serve as kind of a reminder for them. Other advisories we use, we have do not use prime function. So here we have said line primed with drug, there's a bolus risk. So oftentimes in the oncology setting, we're working with not only high alert medications, many of these drugs are considered hazardous drugs. And so for us, we have made the decision where pharmacy will prime the majority of lines down in the pharmacy in the hood. And rather than asking our nurses to perform this function on the floor. And the idea is that by doing it in the pharmacy, our staff are more protected by doing this in the hood and minimizing exposure to these hazardous medications. But with that, we recognize that our nurses need to know what the line is primed with. So is it drug, or are they able to use the prime feature if it's diluent, which will infuse the medication in the line rapidly, usually 999 mLs per hour, to have the medication reach kind of the entry of the patient. But again, recognizing that we don't want to use that feature if the line is primed with drug. Apologies for the overhead. Let me just give 1 second. Okay, sorry about that interruption. Great. So in addition to using clinical advisories, I mentioned before the use of modifiers to allow for narrower limits. So again, recognizing that high alert medications have the risk of causing harm if they are given outside of the way that they're intended to be given. We have recognized that the use of modifiers allows us, again, to have more narrower limits to prevent those programming errors from reaching the patients. And so this is something that we leverage in, I would say, the majority of our drug entries. Right. Next, I wanted to talk about multi-step programming. And so this is a feature that's available, again, in many smart pumps. And what this does is it allows for a medication that is going to be titrated up. This is different than, say, for example, a pressor in the critical care setting where you are titrating to an effect. The examples I am referring to here are medications that will say you'll titrate it at this rate for 30 minutes. If the patient tolerates it, we'll step up for the next 30 minutes and so forth. And so for our practice here, we leverage the multi-step programming to allow the independent nursing double check to occur before the pump is actually started. So the first nurse will go in, program each of the dosing steps or the rate steps along. You can see them kind of along the top as you go ahead and proceed through. That way, the nurse can compare what has been programmed into the pump to what is ordered in the electronic health record before the pump is even started. And so thinking about what medications you have that are going to be titrated, this is a great tool that you're able to leverage. The one caveat or one thing I will say that has been definitely a hot topic in the oncology setting or the areas that I've worked in is that there is no sort of callback with this feature. So if you are going to go ahead and leverage it, you just want to be kind of aware and considerate of the fact that once it passes through the first rate, the pump is automatically going to flip to the second rate. So if it's a medication that has a high risk of an infusion-related reaction or HSR reaction, you might not want to allow the multi-step programming. You might want the nurse to come back, do an assessment of the patient before they program the pump for the next rate. So definitely pro, cons, kind of risk benefit with this feature, but it is something that we have used for many medications that we know that can be safely titrated up. And then that allows for us to do this independent double check without having to constantly interrupt another nurse to have them come do multiple double checks as we change each rate and kind of pulling them away from other tasks. And then lastly, the other kind of food for thought here I wanted to highlight under them being high alert medications in the oncology setting is that oftentimes, at least in the inpatient setting, we will have multiple different libraries that are available for the nurses to use. So for example, Med-Surg will be a separate list of medications than the oncology library medications. And so if we have patients that are receiving anti-cancer care or treatment outside of an oncology unit, just ensuring that there is kind of policies or there are workflows in place to help support the nurses for still using these limits or the libraries with the limits for these high alert medications, even if they're treating a patient where maybe their primary library entry that they'd be using is critical care, for example. So one way that we have done this is, oftentimes pumps will allow for multiple channels to be attached to one brain. But that way is mostly you're going to be using one library. So what we have recommended for our patients is that they would have one pump that could be infusing the medications that are specific to that care area, such as critical care. And you can use a separate pump and still use the oncology library so that you are running these high alert medications using the limits that are available, but not compromising the care of the other medications that they're receiving in that area. So the next challenge I wanted to talk about here is the unique or complex administration instructions that we oftentimes see with these medications. So more and more, we do a lot of clinical research where I work right now, and more often than not, I feel like we're seeing these very complex administration instructions kind of coming through the clinical trials and eventually being approved, and how the drugs are being brought to market. And so this is just an example of one medication here. The drug is generic name zolbetuximab, and it has a unique administration way of being given. So the first dose is going to be given at 100 milligram per meter square per hour for 30 minutes. And then the subsequent infusions can be given over a range, but also using a unit of measure of milligram per meter squared per hour. And so when we were onboarding this medication and it was coming in through our interdisciplinary pump committee, we were recognizing that the BSA based rate was not available in the infusion pump that we use within our institution. And so we said, okay, let's look at our other systems. Can they do something there to help us, translate it into a unit that the pump will recognize? And unfortunately, our electronic health record also could not calculate the rate for each step of this titration using this unit of measure. And so recognizing, again, these are high-risk medications. It has complex administration instructions. Our kind of committee, again, great having that sort of multidisciplinary approach already in place, was able to brainstorm different solutions for addressing this. And what we did was actually use kind of a combination of features that were available in the pump, such as the clinical advisory, as well as other features within the electronic health record to help guide the appropriate administration of this medication. So the reason I wanted to highlight this example is that with these new medications coming to market that might be recommended to be administered in a new way that we haven't seen before, definitely recommend, contacting your pump vendor. You can also contact your electronic health record team and see what options are available for building. But even if something's not available to you right away, would encourage you to kind of think outside of the box and see what tools are available, some of which we might have gone over today, that you can leverage to help make this as safe as possible while you work on maybe a longer term strategy. All right, so next I want to talk about lookalike medications, which is definitely something that is not unique, I would say, to the oncology setting. But I do think it's something that we commonly see in the oncology setting. So oftentimes we're using monoclonals. And so a lot of these medications will sound very similar. So any of the MABs, for example. Recently, we had a slew of medications that were just approved that started with the letter Z, which is something relatively unique, I would say. There weren't many other anti-cancer drugs that were starting with Z, and there were about 4 or 5 that were brought to market within a few months frame. And so this was something that our team had a lot of discussions about, and want to kind of walk you through sort of the way that we've thought about approaching these to prevent administration errors with these meds. So one of the most obvious, I would say, kind of strategies is the use of tall man lettering. And so for those of you who are not familiar with this strategy, it is when you use capitalized letters to draw attention to the differences in lookalike medications. So you can see on the screen here, we have trabectedin and trastuzumab, but both of those start with the TRA. So we've called out the differences there. We want to make sure whenever we're making these changes to the pump or the way that medications are going to appear in the pump, that is in alignment with our institutional policies and the way that the drugs will appear in our other systems. One of the biggest things, though, that we've considered when we're thinking about the need for tall man lettering or any sort of additional warnings within the pump is we consider how the medication will be searched within the pump library. And so depending on what pump you're using, the nurses or the end user will pull up medications in a different way. For us at our institution, the pump that we use, we are prompted to enter the first 2 letters of the drug to pull that name up. And so oftentimes a medication could be a lookalike medication if you're just saying it out loud, or sounded like medication if you're saying it out loud or looking at it on paper. But if those 2 letters are not similar to each other, those are not going to appear as options next to each other on the pump. And so rather than sort of overusing this feature of tall man lettering, we always will do an assessment to say, okay, when we type in the first 2 letters, what other medications will appear? And then if you were to select one of the other ones, what is the risk of a programming error or it reaching the patient, and what's the potential harm if we did it? So would you be able to program this dose? Would you give it 2 times faster, 4 times faster? And do we need to put additional strategies in place? But kind of like alert fatigue, you don't want to obviously overwhelm the end users with alerts. You also don't want to overwhelm them with the use of tall man lettering, because the more you do it, the less value it's going to be. And so I would definitely encourage you guys to kind of consider how these medications will appear on the pump screen and whether you feel like that will be a valuable addition. And so in addition to the tall man lettering, we will also leverage clinical advisories, which, as you can tell, I told you at the beginning, love clinical advisories. And so that is something that we use here to note if a drug is a lookalike sound-alike, to serve as sort of an extra reminder for the nurse to check. All right, last 2 challenges I wanted to cover briefly are we use a number of desensitization protocols here. And so what that means is the patient has had a reaction to the anti-cancer medication. They are referred to our allergy clinic, who will recommend a desense protocol, which is giving the medication to the patient, very small doses, and they will titrate it up to see if the patient is actually able to tolerate the medication. And then also, as I mentioned, we have a number of clinical trials that are going on. And so when we're thinking about our build principles for the library, again, we want to make sure that all of the orders that the nurses are seeing within the EHR are available to them in the pump. But those 2 areas are kind of ones that have caused us particular challenges. And so I will go over a few solutions, but also would love to hear if you guys have other ideas of kind of how you're managing this. But basically, our overall build principles right now has been that we will add medications and doses that are approved and in commercial orders within the EHR to our library. And from there, we will add doses and dose modifications, again, that are available or built into those orders. And then we have our weight-based and BSA-based medication limits built off of predefined lower and upper limits that have been approved by the Smart Pump Committee. So what you'll notice here is that what is not available in this drug library is any research drugs. So you'll notice here we build commercial drugs. And then the reason that this does not encompass desense drugs is because those doses are going to be much, much smaller than what a patient receiving the full dose would receive. And so there are kind of a number of reasons that we have chosen not to build those into our library. One of which is that there are rapid changes to research protocols that are happening on the daily. And so while we are updating our pumps monthly, that would not necessarily be enough to capture all of the changes that are coming through research protocols. We also were concerned about selection error. So one medication can be used on a number of different research protocols. And so the more options you have to choose from for the same drug, the more opportunities there are to select it in error. And then lastly, any medication can be given in the desense clinic. And so we would have to have every medication available, but even more so, the doses are customized to each individual patient. And so having narrow limits wouldn't really make sense here because, again, the dose is going to be specific to the patient. So kind of recognizing this, we have built out what we call either ID or investigational drug entries, as well as desense drug entries. And the reason we've chosen to do this rather than just using basic infusion is we have been able to limit the different units of measure that are available. So for example, we'll have milligram per kilogram, for example, but units of measure that are not commonly seen within any of our orders, we do not have available on these kind of generic entries. Right, so now at the kind of getting towards the end here, I want to just quickly talk about measuring and kind of the data that we can pull out of the pumps. This is a topic I would say all in itself, and I could talk about this forever, but I'm going to move through this for the sake of time, but happy to chat with any of you guys afterwards, or if you want to contact me after, would love to talk more about this with you. So ISMP does recommend that we should monitor how often the pumps library is used. And by doing so, we're able to also identify and address any obstacles that are preventing library use. So the communication tool we talked about before. And they also recommend doing walk rounds to observe how pumps are used in real life situations to really kind of validate the data that you might be seeing or pulling from these pumps. So on this screen here, I wanted to show you an example. This is a run chart that we use to track the overall compliance with the use of DERS at a previous institution. We had recognized that we had opportunity for improving our compliance with DERS, and we used a PDSA methodology to do a number of different changes, all targeted at improving the compliance and the use of DERS. So what you're looking at on the screen here is a overall compliance of the whole institution. But what I wanted to call everyone's attention to here is that PDSA Cycle 5, we did specifically target the oncology areas. So what we had recognized is that they were particularly prone, I would say, to kind of this belief that the medication that they were giving would not be in the library. And it goes back to a number of the challenges we talked about before, but most commonly it was that, well, we're getting new drugs all the time and you guys aren't adding them fast enough. And so that was something that we were able to identify throughout looking at the data, but also throughout walk rounds with the frontline staff to target a particularly high risk area. So the reason I brought this example forward is I wanted to share is that it's definitely helpful to use the data, but you definitely need to couple or kind of pair the data review with conversations with the frontline staff. Because if you're only looking at the data alone, sitting at your computer by yourself, you're definitely not going to be getting the full picture there. So in addition to looking at overall compliance, another way that we have used data from our smart pumps is to evaluate compliance with specific initiatives that we have going on within the oncology setting. So just one example of that here is that we do something called a taxane titration protocol. And this is because taxanes have a particularly high incidence of causing hypersensitivity reactions in patients' first and second lifetime doses. And so in collaboration with our allergy colleagues, nursing, pharmacy, we were able to develop this protocol where we are able to titrate patients up when they're receiving Taxols for their first and second lifetime dose in the effort to decrease the incidence of hypersensitivity reactions. When we went live with this initiative, we wanted to make sure that our nurses were actually doing this practice rather than just using a taxane, paclitaxel, for example, entry and just administering it the way they had been used to over an hour or 3 hours, for example. And so we were able to leverage the data coming out of our smart pumps to monitor compliance with this titration practice. And that way we could link whether a patient had reacted to the medication. Was it due to them having a reaction, or was it possibly contributed to by them not using this titration? So this is just to show, I think a lot of times when we think about data, oftentimes we think about measuring compliance, but it also can be used to measure specific initiatives that you have going on within the oncology setting. And then lastly, alerts. There is so much wealth of data here. And so analyzing hard and soft stop data alerts can help you identify changes that may be needed to the library to reflect practice changes. And so for us, for example, we had recognized that one of our areas was actually doing a titration protocol, not the taxanes, a different medication, that we weren't aware that they were doing it. It was a disease group specific area who had wanted to trial to see if this was available. But each time that the nurse went to program it, they were hitting alerts, soft alerts. But it was making the nurses not want to do the titration because it was much more cumbersome for them to program the pump. And so this was a way for us to identify that something different was happening here. And we wanted to collaborate with that disease group to build out an entry that would appropriately reflect the practice that they were trying to test. All right, so in summary, IV smart pumps are a critical safety tool in the oncology setting when they are optimized. Creating oncology smart pump entries is uniquely challenging due to rapid drug approvals, frequent guideline updates, the high-risk nature of medications administered in this setting, and the oftentimes complex administration requirements that are associated with these medications. So we've gone over some strategies today, such as the formation of an interdisciplinary smart pump committee, leveraging available smart pump functionalities and aligning them with other technology systems. And all of these together can help minimize these risks and ultimately optimize our patient safety. And then lastly, I know we didn't spend a lot of time on it, but again, happy to chat about it after. Using data and monitoring library compliance enables continuous improvement of the library builds, which can tighten unsafe thresholds, eliminate low-value alerts, and allow the alignment of limits with real-world practice, which again ultimately will improve patient safety and workflows. With that, I will turn it back over to Sammy. Thank you guys all again so much for attending today and looking forward to hearing your questions.
Thank you, Emily. Such a great presentation with a ton of tips and tricks for the oncology setting. So thank you. On this screen, we'll leave this up during the questions. If you have a few minutes, this is just a short survey. Please let us know your feedback. We're always looking to make these medical education webinars better and would be interested in what future topics you guys would like to have. So please fill that out if you have time. And then we did get some questions. Hopefully we can get through a couple of those. The first one was around overfill and how you are specifically accounting for that.
Great question. It's something that still comes up every day. So for us, we have sent our electronic health record for anti-cancer agents specifically to account for the overfill in the bag. So we have worked with our bag vendors to get an estimate of the overfill based off of each bag size. And then we have built that into the electronic health record. And then subsequently, we mirror our library, our IV pump library builds based off of that. There are some medications that we're giving in this setting, such as like iron, for example, that our electronic health record does not recognize as anti-cancer. And so in current state right now, our pharmacists are manipulating the order to account for overfill. But for those examples, rather than it being a fixed dose strategy, we have done it as variable to allow for whether that final volume is going to account for the overfill or not. But great question, is definitely something that we're still working through, but that's kind of been our current practice right now.
Thanks, Emily. The next question was in regard to your MAR communication tool. And there was a question if you have other drop-down choices besides just the basic infusion.
Yes, so there are other options, and I've kind of graded them out as well. But so other examples are that the ADM is out of medication, they're missing a patient-specific medication. I do believe, depending on what vendor you use, they're going to be kind of suggested ones, but it is a customizable list that you're able to work with your IT team or your electronic health record team to add options or kind of customize it. So yes, there are other options, and every once in a while we would get a message that had a different reason. So for example, I would get a message that would say missing patient specific med. And so would have to write back saying, sorry, wrong reason, please, send again. So it would go to the right queue or the right person to review.
Got it. And then probably have time for one more question. This one was related to the multi-step feature that you talked about. What if an infusion reaction occurs in the middle of that sequence? Is there a process? Do they stop it? How does that work?
Yeah, great question. So for us, it depends on the severity of the infusion related reaction. But the nurse will definitely pause the infusion. And then again, depending on the severity, we have an algorithm that's built in that will include what next steps are needed to be taken for restarting the infusion and how they should restart it. Oftentimes, I will say they will back out of it and kind of start over, because the majority of time, if they're having a reaction, they need to restart at a lower rate if they deem that the patient's able to be restarted. So great question. And short answer is that we have it built into our infusion related algorithm to help guide the nurse on what they should do.
Awesome. Thank you so much, Emily. If you jump to our last slide, this is just a reminder that the recording for this webinar will be posted on our News to Infuse website. If you're not familiar, you can scan that QR code and it will take you there. All of our previous recordings, previous webinars, the recordings are posted there. But thank you so much for attending today. Thank you to Emily for a great presentation, and we look forward to seeing you on the next one. Have a great day, everybody.
Thanks, everyone. Bye.